So, good evening, all. Now we are again into this very popular and wonderful learning series from IAP NRC, that is Advanced Pulmonology Clinic. Dear delegates and seniors, we all know that even though life is not all black and white, lung is mostly black and white and a little bit of gray. And for today's session presentation, we are having one of the most reputed institute of our country, that is AIMS Rishikesh, with session mentor being Minu Singh ma'am and another of her faculty. And the moderation will be done by none other than wonderful Dr. Kamal Kumar Singhal. So over to you, Dr. Kamal, to introduce the mentors and speaker and lead discussants and to carry forward the program.
Thank you so much, sir. Thank you so much. So I think straight away we have Dr. Minu Singh ma'am as a mentor and Dr. Vyas as mentor. So we'll straight away request the presenter to please share the slide. Dr. Man Singh, to please share the presentation.
Okay. Good evening, sir. Good evening, all.
Dr. Man Singh, you are audible. We are waiting for you to
sir.
share the slides.
Okay.
Yes,
Sir, my screen
we can see
now,
the
sir?
slides. Just put it in the slideshow mode. Yes, perfect. The slides are visible. You are audible. Let's start.
So, good evening, all. Today I am presenting an interesting case of curious case of persistent opacity. My mentor is Professor Minu Singh and Dr. Vyas Kumar, sir. So, he is a 6-year-old male child. He is resident of Bijnor, Uttar Pradesh. Was admitted to us on 19th of March and discharged from our institute on 4th of April. He presented with complaint of recurrent episodes of blood tinged sputum for last 2.5 months duration. So first episodes of blood tinged sputum was started from on Jan 1st when parents noticed blood in oral cavity. It was fresh blood. Amount was around half a spoon. However, it was not any cough and vomiting, any shortness of breath. After that, child remained well okay for next 21 days. And then child again had second episodes of blood in sputum. This time it was just cough. It was fresh and amount was around half on same. And it was not also any shortness of breath. Then child remain okay, outside admitted, and then remain okay. Then child had third episodes of blood in sputum on 14th of March, 5 days prior to admission. It was cough, it was fresh blood, and amount was this time was very less, around 1 to 2. And there were not actually any shortness of breath. But from this episode, child also started with persistent mild cough, wet cough, but there were no still any fever cold. There was no still any fever or evening rise of temperature. There was no still any decreased appetite, weight loss, poor weight gain. There was no still any fast breathing, chest drawing, and shortness of breath. There was no issue of any pain, abdomen, vomiting, constipation, lymphadenopathy, seizures, and encephalopathy, indicating there is no other evidence of any tubercular meningitis or extrapulmonary TB. There was no issue of bleeding from any other side. There was no issue of any loose stool, oily stool, recurrent nasal symptom, or expectoration. There was no issue of any chest wall pain, no issue of any atopy or environmental trigger. There was no issue of any trauma, foreign body aspiration. There were no history of any palpitation, orthopnea, PND, and cyanosis. There were no history of any rashes, joint pain, swelling, decreased urine output, and blood in urine. There were no history of any blood transfusion. But child had prior to this illness, 2 months back, child had fever and cough of around 1 week duration. For this in October 24, and for this child was admitted for 5 days and received IV antibiotics. Our parents give history that they were at that time there was no any fast breathing, chest syndrome, and hemops, blood in sputum at that time. After that, 5 days child remain okay for next 2 weeks. In family history, child was born to first born to non-consanguineous Mary. Mother had pulmonary TB 5 years back when child was 6 months was old, and it was microbially confirmed TB, and she taken ATT for 6 months, and then she was declared cured. And for these episode of hemopsis, for first episode on 1st of Jan, child receive oral medication for 5 days on OPD basis. And for second episode of hemosis, child admitted outside for 13 days and received IV antibiotics. And parents said, the doctor said the child is pneumonia, and that's why child have to give these IV antibiotics. Birth history was child was full term normal vaginal delivery, cried immediately after birth. Birth weight was not known, but there was no any NICU stay and no neutral jaundice. Child was completely immunized till 18 months. 5 years they missed the dose, but disease scar was absent. Child is developmentally normal, studied in class 1 and good in study. Socioeconomic state, the child belongs to lower middle class. So in database, we have 6-year-old male child, developmentally normal, incompletely immunized, now presented with 3 episodes of hemopsis over last 2.5 month duration, with having cough for last 5 days, with past history of pneumonia 5 months back, for which require IV antibiotics.
Good, Dr. Mansingh. I think here I will bring in our lead discussants. First of all, Dr. Subhashish Roy, sir. Sir, in this presentation, any clarification that you wish to seek on history?
Any coagulation profile has been done?
So I think
Yes,
the pattern is such that we will first go through the history and
Okay.
then examination and then investigation.
So in the history, there are 3 episodes of hemoptysis, 1 episode
Yes.
of admission for pneumonia, and
Yes.
and the third for the second episode he was admitted and there for 2 weeks.
Around 2
Admit-
weeks, 13 days.
Around for 2 weeks. The child is on. Otherwise, the child is not on any medication for any other disease.
No, sir. Child is not on any other medication, sir.
Fine. Continue.
Dr. Praveen.
Yes. Well, Dr. Mansingh, you have presented very well. I have a couple of questions related to hemoptysis. So first he was symptomatic in October and then he has started bleeding in January. So how
Yes,
is
sir,
the
yes.
child in between the episode from the October to January? Was he completely normal? My second
Yes, sir. He
question is
was,
that what is the characteristics of the blood? You have told about the amount, but what was the color? What was the material, other material associated with the blood? Now, third question is that was the child having any upper respiratory tract symptom, like any nasal symptom or any other upper respiratory tract symptom? And how you know that it is the blood which is coming from the lower respiratory tract versus the upper respiratory tract? So you have to ask about it. Fourth question, is there any history of foreign body aspirations by anyhow? So
No,
these
there
are
was-
just couple of questions I just wanted to clarify.
yes, sir. So regarding first question, sir, child was completely well from October till next 2 months, sir. And for the October, child was only having this fever, cough, and there were no any fast breathing, but child was admitted, received 5 days antibiotics. Sir. Regarding characteristic of blood, it was fresh blood, sir, and there were no associated any upper respiratory symptom. There was no cold, no nasal symptom, nothing was there, sir. regarding the blood from origin from upper respiratory tract or lower respiratory tract, sir. Regarding this first episode in January, the parents noticed that blood was in mouth cavity. So we are not sure it was from GI tract or respiratory tract. I am not sure. But from second episode, their child had cough and spit out blood. So upper or respiratory tract, it is difficult to say, but that child was not having any upper respiratory symptom like stridor or change in voice at that time or some sore throat, other thing. It was not there, sir. So it maybe looks like maybe a lower respiratory tract. And
GI
foreign body,
symptom?
so there was no GI symptom, no vomiting, no pain abdomen. And
Okay.
regarding foreign body, I asked typically, but they were saying that they have any time they not notice any choking or such episode, sudden bouts of cough, other symptom. These were not there, sir.
Okay, great. Thank you.
Okay, thank you,
Over
Dr.
to-
Praveen. Thank you, sir. We'll call you in again. Dr. Mansingh, just 2-3 things we have in chat box. How do
Yes, sir.
you assess this that the mother has taken antitubercular therapy 5 years back? So how do you, in the light of this illness, how do you analyze that?
So child is not fitting in this criteria of contact, sir, because it is all more than 5 years. But this also was not given that INS prophylaxis also. And if any other family member, though no other family member having symptoms such, so it is less likely to be affected. This, but if any family member is there in family which is having TB from this
Okay, fine.
child.
So the question is that the child has not been given chemoprophylaxis.
Yes, sir.
Fine. Any other, your presentation probably, is there any other bleeding manifestation which can mean hematuria and so on?
Yes, sir. That I already told you. I already presented that there was no history of bleeding from any other side, no hematuria, no
Perfect.
skin bleed, nothing like this.
Any renal symptoms?
No renal symptoms. No.
Any
Particularly.
edema, cardiac symptoms, cyanosis?
No, sir. There are no issue in orthopnea, PND, even shortness of breath, palpitation was not there, sir.
So what we understand is it otherwise looks like that there are no constitutional symptoms, and he only has episodes of fever, episode of cough and some hemoptysis, but otherwise he's fine. In between
He's
also, otherwise also, so no constitutional symptoms. So let us look at the differential diagnosis that the treating unit has thought of, and we'll bring in the lead discussant at that time. Yes, Dr. Bansingh, please proceed.
Yes, sir. Based on these, we kept possibility of first is pulmonary TB because of child is having a cough or more illness of more than 2 weeks duration, and child was also having hemoptysis. And but odd point was there was no fever, there was no weight loss, no poor weight gain, and this was the second possibility. It may be some pulmonary malformation, CPAM, or some cystic lesion like organ duplication cyst uh, or some hydroid cyst or some sequestration because of recurrent hemoptysis for last 2.5 month duration. And child was asymptomatic from birth to till October 24, around 6 years of age. So this is odd point. Third possibility, it may be complicated pneumonia, like pneumonia with lung abscess or empyema, but because of illnesses of around 2.5 month duration with hemoptysis. But odd point is there's no history of fever, no history any time of fast breathing, chest wall pain. Yes, but child received IV antibiotics 2 times in last around 5 months. Another possibility may be malignancy, like any ring sarcoma or rhabdomyosarcoma or thing because of hemoptysis. And but other constitutional symptoms are not there. These are the guess. So these are my possibilities at the time of presentation.
Fine. Dr. Subhashish Roy, do you agree with the list of differentials, or you would want to?
Well, one thing is certainly it is not a pulmonary TB. The history does not fit into the pulmonary TB because rarely we can have a hemoptysis in this age group. and the child is not having any constitutional symptom, there is no fever, the child is not having a persistent cough. Second thing, complicated pneumonia is pretty unlikely because the child is, again, the child is not having any tachypnea, the child is not having any persistent fever or any toxicity. So pulmonary AV malformation can be one of the possibility. Malignancy, of course, yes. Idiopathic pulmonary hemorrhage can be thought of in the differentials, definitely, and any other uh, mm, congenital malformations can be thought of. Yes.
Thank you, sir. So, Dr. Praveen.
Yes. So I agree with Dr. Sabasar, sir. Pulmonary TB complicated pneumonia looking less likely because in between the child is totally normal. There is no any constitutional symptom as well. Malignancy, we can think, but it is a lower down and it is an intraluminal tumor, like the inflammatory myofibroma or maybe the carcinoid, not the rhabdomyosarcoma will not present like the hemoptysis. We can think about the foreign written foreign body and another, from my point of view, we can think about some vasculitis. And we have to look for the other symptoms, other systemic involvement as well. So in these cases, we will think about the congenital malformation, maybe which is having the due to the infection, having the infection, latent foreign body, vasculitis, or maybe pulmonary tuberculosis could be, but should be very lower down. So not at the first, might not first diagnosis the pulmonary tuberculosis.
So yes, Dr. Praveen, thank you. So what we all agree is that looking at this clinical scenario, when you do not have constitutional symptoms like fever, weight loss, decreased appetite, then infections come very lower down in this list. We would not think of infections because usually infections will be associated with some kind of fever. And in between illness also, the child will not be completely well. That brings our infections a bit down. This is what I think Dr. Praveen and Dr. Subhashish Roy are trying to say.
Yes.
And then it boils down to some kind of a bleeding disorder or structural malformation or congenital defects or cardiac defects. So I think I also agree that that's why pulmonary TB is a bit misfit as a first differential. But yes, rest all to an extent can. But infections we will keep lower down. In the chat box we have why not autoimmune? Dr. Mansingh, why not autoimmune?
Yes, because of the child was not having any other, let's say, joint pain, joint swelling, no fever, and just because of this, and also there was no any shortness of breath. So because of this, I have not get possibility of this autoimmune disorder.
Yes, agreed. But again, then in autoimmune also you have some kind of a fever and all that can be maybe there in autoimmune also at times. But yes, all things you pointed, they will take you a bit away from that. Idiopathic pulmonary hemosiderosis.
For this child should have some at least if bleeding is there, so child should have some bleed and child should require some time blood transfusion or some shortness of breath at least. Child never had any shortness of breath, never massive bleed, never required any transfusion. So slightly because of this I haven't get possibility like this.
So yes, the word idiopathic would not come at this point of time. It's pulmonary hemosiderosis.
Yes.
After all, everything is negative, then it becomes idiopathic.
Yeah.
But yes, the probability that we are discussing is pulmonary hemosiderosis. But depends whether it is a venous kind of a bleed or a bronchial artery kind of a bleed. In venous bleed, you can have low-grade bleeds going on for very long, but then they present with significant anemia. And in bronchial artery, you can have a torrential kind of a bleed. So overall, never required any transfusion. So chronic low-grade bleeding going on for very long looks less likely. I think from here on, let's proceed with the examination.
I have one question. Why you are not keeping the possibility of a foreign body?
Foreign body is maybe possibility.
You may not have a history of choking in all the foreign body cases. So why that possibility is not here?
It may be there.
So I think what they're trying to say is that they have asked for a for one of the pointers on history. They do not have it.
Yes.
But yes, in a patient like this, in such a young child, at times you may miss it altogether. But then in a 6-year-old child to say that it will completely miss, it is a bit difficult.
Right.
He's still big enough to at least tell you. until unless it's a long forgotten kind of a foreign body.
Right. Yes.
So, Dr. Mansingh, let's proceed with the examination.
I
Yes.
just want to clarify one point. At this point of time, we don't know whether it is coming from the upper respiratory tract or lower respiratory tract. So first of all, by examination, we have to rule out whether, because the amount is very low, 1 or 2 ml. So it could be from the upper
Yes.
airway as well. So we have to first exclude whether this blood is coming from the upper airway rather than lower airway. Okay, please go ahead.
So on examination at presentation, the heart rate was 102 per minute, respiratory rate was 24 per minute, CRT was less than 3 seconds, central and peripheral pulses were well paperable, blood pressure was 106 by 76, and saturation was 99% under room air. On anthropometry examination, weight was 17.1 kg, which was between 0 to -1 SD. Height was 114.5 centimeter, which was also between 0 to -1 SD. BMI was 13.0. So child was having normal anthropometry. On general examination, child conscious oriented. There was no pallor, no icterus, no cyanosis, no clubbing, no edema, no any lymphadenopathy. On head-to-toe examination, one capsulate spot was there on anterior abdomen wall, but no other abnormality in head-to-toe examination. On upper respiratory examination, there was no negative nasal symptom. There was no turbinate hypertrophy. On oral cavity examination, there was no tonsil enlargement. Oral hygiene was good. Ear examination was normal, and there was no any evidence of some local bleed. On lower respiratory examination, on inspection, the bilateral equal expansion was there. There were no scar mark, no engorged vein, no solid dropping scoliosis. There was no subcostal intercostal retraction. On palpation, there was no tenderness. There was no local rise of temperature. Trachea was central. Chest expansion was equal bilaterally. Pectoral fermentations was also equal in all area. And apex beat was also in fifth intercostal space in mid-clavicular lung. On percussion, there was some impaired note was there in the right infraclavicular and memory area. And in the rest area, there was resonant note. Liver dullness was in fifth intercostal space and liver span was also 7 centimeter. But on auscultation, there was mild air entry reduced in the right infraclavicular, memory and axillary area. There was bronchial breathing was present in the right infraclavicular area and memory area. And there were no other edits. And the vocal resonance was equal in all area. So there was some focal lesion in the right upper lobe consolidation. Rest of the examination, including the CNS and CVS, was normal. S1S was normal. There were no murmur. And upper abdomen was soft, non-distended. There were no tenderness, and there was no hypothermia. So now completing the database. Now 6-year old male child, outer mobility normal, completely immunized for age. Now presented with 3 episodes of hemoptysis over 2.5 month duration, with history of cough for last 5 days, with also having history of pneumonia 5 months back requiring IV antibiotics. On examination, child is having normal anthropometry, impaired percussion note in and reduced air entry and bronchial breathing in the right infraclavicular and memory area. Sir,
Okay,
any
thank you.
clarification in the examination?
Yes, Dr. Mansingh, thank you. Dr. Praveen Kumar.
Yes, sir. So what is the interpretation of the respiratory examination findings? What do you think? What is the underlying process?
So it looks like there was some area of consolidation is there in the right upper lobe. Upper
Yeah,
zone. Right.
it looked like there may be some underlying cause. Yes, go ahead.
Dr. Subhashish Roy, sir. Am I audible? Hello.
Yes, sir, you are audible.
Dr. Subhashish Roy, any
Yeah.
clarification?
Clarification is the cafe on the spot is only one. Have you examined properly? Is it only one?
Yes, sir. It was only one or the anterior
Have you
abdomen wall.
stripped the child and examined the other parts of the
Yes,
body
sir.
also?
Yes, sir. Yes. There was only it was only one.
And you told ki there is a bronchial breath sound with a normal vocal resonance. Are they go hand in hand or is it contradicted?
Yes, sir. Yes, sir, they are not going hand in hand, but it was there. So it was only slightly mildly reduced, and but there were bronchial breathing signs for this.
Okay. Okay.
So, Dr. Mansingh, now we have a child. Now, if we look at the story again, a child who does not have any constitutional symptoms comes to you with one episode of pneumonia almost 5-6 months back, and then 3 episodes of hemoptysis, isolated, discrete episodes in between. Well, he's not having any fever or a weight loss and anything. And on examination, you see the anthropometry is normal. And I think single FKFA Olay spot can be a normal presentation in many healthy children.
Yes.
So if we lose that, just one clarification, if you either have consolidation or you have something else. So when you say that on examination, a particular spot was showing impaired note and bronchial breathing, but a normal VR. That's a bit odd. So any take on that? Your vocal resonance was normal in the area where you see we are saying that there was consolidation. Is it odd?
It's correctly what, sir. But I feel at the time examination that was normal. This was equally coming. So it was slightly odd. It should be increased. If there is consolidation is there, VR should be increased.
So usually in clinical examination, we say that on auscultation, the vocal resonance and on palpation, the vocal fremitus, they more or less go hand in hand. There will not be a clinical scenario where the vocal fremitus is raised, but the vocal resonance is less. They more or less same the same thing, just that you are eliciting one thing with the stethoscope and you are palpating it with the hands. Otherwise, they mean the same. So usually the VR and the VF they go hand in hand. By going by your description of consolidation, it looks a bit odd. But other thing is the breath sound is reduced in that area. Because in a consolidation you will not have a reduced breath sound. You will have a vocal resonance which will be raised. You will have dullness, but the air entry is not reduced.
Sometimes if consolidation is there, that all area are filled with exudate. So it may be possible that because of this we
So
have less air
the
entry.
point is that if the lumen is patent, then the breath sounds are conducted to the chest directly because of the consolidation. But the lumen, if it is patent, you will not have reduced breath sounds. It can happen if there is an intraluminal obstruction, like a foreign body. It can happen if suppose there is something obstructing the lumen or there is a significant collapse. But otherwise, it will not happen. So there are a lot of questions regarding this thing only. That's why I asked you and we clarified trying to do that. Somebody says, can it be a mass like a hydrated cyst? No pulmonary disease, BMI is not normal anthro. So Dr. Mansingh, there is a question, is the anthropometry normal?
So weight is 17.1 kg between 0 to -1 st, sir. Height is 114.5 centimeter.
So
It
there
is
is a
also 0 to
comment that BMI
-1
of
st.
13 is not normal. So do you agree with that?
13 is less, sir, but it was coming up to 0 to -SD. If you take weight for length, this is just 6 year. So weight for length is 0 to -SD is okay.
Yes. So the BMI is also age dependent. You cannot compare an adult's BMI with a
Yes, sir.
child. The same BMI in a 6-year-old child can mean normal, or suppose an 8-year child, it can be normal, and a 6-year child, he may turn out to be an obese. So the BMIs are age dependent. So it's very good that you have thought in terms of Z scores. And if the Z scores are normal, then this BMI is normal. In pediatrics, we do not have absolute numbers like we do have in adults. Fine. So let's look at your differentials.
So differential here would be first possibility because of some a focal finding we have an examination. So some these sequestration, cystic lesion or CPM will be over the first possibility, sir. And because of recurrent hemoptysis and focal lesion, however, no past history. TB, as we discussed it previously in at the time of history after that. So it is now because of its symptoms and constitution are not there, it is less likely. Malignancy is still possibility because of hemoptysis as well as focal finding on the one side, and pneumonia is also less likely. Yes, forgotten foreign body is still a possibility because of focal lesion. It may be there is some obstruction in the right upper lobe because of this having child is having all these symptoms.
Dr. Subhashish Roy, do you agree with this set of differentials?
Yeah, I agree. But the thing is that the physical examination points towards a collapse consolidation. And more likely, there should be something in the airway. So I still request you to consider the foreign body or any mass or anything in the airway. Simply a consolidation will not give recurrent hemoptysis. A simple consolidation will not be without any constitutional sign is very unlikely. Cystic lesion, yes, can happen, definitely. But still, I think something in the, and malignancy definitely a possibility.
Okay, thank you, sir. Dr. Praveen Kumar.
Yeah. So, well, one thing again, pulmonary TB can present as any characteristic symptom in India. I will not disagree. It is not a pulmonary tuberculosis even without fever. I would still keep pulmonary TB, but lower down. Regarding the congenital malformation, because here looking lesion into the upper lobe, and CPAM and sequestration, they are more likely in the lower lobe. Whether it is right side or left side, they are more likely in the lower lobe. If you're thinking in the upper lobe, it could be some bronchogenic cyst or some other focal duplication cyst, or unusually, maybe sometimes CPAM you can get also into the upper lobe. But if you're in the context of congenital anomaly, if you think about that, then the bronchogenic cyst or other focal duplication cyst is more common in that position. If you're thinking about the malignancy, we could think about the intraluminal malignancy rather than external malignancy, like again, as I told, carcinoid or any bronchial adenoma. And we still think is some retained foreign body, but because here the lesion looking into the right upper lobe, so now I will not think about the foreign body more likely in this case, because foreign body usually maybe in the lower side or lower lobe, but here examination finding more onto the upper lobe. And complicated pneumonia, I don't think it is the cause in this case, no. So pulmonary TB still I can think, yes, it could be, we have to exclude at least pulmonary tuberculosis. Okay. Again,
can I say something on this?
Yeah, please, ma'am.
Yes, ma'am. Yes, ma'am.
You know, in PGI, we had a large number of cases of hemoptysis coming, and we had a large series also. So in that analysis, what we had found is that hemoptysis, when it is occurring in the absence of any fever, you know, otherwise you think of fever and cough, you always think of tuberculosis and you try to rule it out, which seems to, but in this case, that doesn't seem to be likely. And pure hemoptysis occurring in patients, we found that hydrated cyst was something which was, you know, coming very high on the cards. Although Kamal said that infection should not be thought, but it's a parasitic infection only. And somehow in that series, which we had presented also, the hydrated cyst was one of the topmost causes of our patients who were coming to PGI. And now I've seen it in Rishikesh also. We see patients who are, you know, having hemoptysis, they turn out to be hydrated cysts many times. Although we have seen other rarer causes also like intrabronchial adenoma, mucoepidermoid carcinoma, and of course pulmonary hemosiderosis, etc. They are more associated with anemia and they have those episodes of, you know, respiratory distress. Along with that, there's pulmonary hemorrhage, and then which gets absorbed and then they become better. So that also has to be considered. But frank hemoptysis, you know, which comes out in these patients is not seen that much as pulmonary hemosiderosis. You see we see more in case of hydrated cyst. It's more common than a foreign body. Foreign bodies would have histories, plus we have to look at other investigations also now, and because there also some differential diagnosis will be settled. But many times we have seen that these patients turn out to be, so that's why at least I keep that possibility high on the cards in these patients.
Thank you, ma'am. Thank you for the kind comments.
It's
And
more
I-
of experience, it is more of experience
ma'am.
of one center and the other center also now. And it happens, certainly some patients come from those areas, where these dogs and sheep and all are staying together and with human habitat. So
Yes, ma'am. So thank you,
I
ma'am.
think there is no parallel in this child.
There was no palace.
So pulmonary hemosiderosis is almost out of the question if there is no parallel. Okay.
So what ma'am was alluding to is very right, that if a hydrated cyst can have can present just like this, but the point is that the first episode that we are talking about in October 2024, hydrated cyst has a habit of rupturing, getting infected. Probably some it will and at times what we have seen is that you will have a patch of consolidation which will be so wide that the hydrated cyst will not be seen. And only when that pneumonia disappears, you will be able to see that hydrated cyst. And then onwards, it will leak off and on in between, and you can have intermittent symptoms in that. So that is well, and not every time he will have fever. That agreed, ma'am. Quite very true.
So that's what is like. It's more experience based and of
True, ma'am.
more
True.
local to our setting.
True. So, Dr. Mansingh, let's proceed further.
Okay, sir. So on investigation, hemoglobin was 11.8, counts were normal, 5300, DLC was okay, platelets were 2.83 lakh. We have gotten GA for Sivnat that came negative, Monto was negative. Urine erythrocyte revealed no hematuria, no proteinuria. PTINR was okay, and RFT renal function was normal. It was liver function, bilirubin, SGOT, SGPT, all were normal. And peripheral image shows predominantly normochromic and normocytic. So these were the serial chest X-ray. We don't have any X-ray of first episode pneumonia that child have in October. This was the first X-ray after the first episode of hemoptysis on 11th January. At that time, the X-ray is showing the area of homogeneous opacity in the right upper zone, and with some area of air bronchogram are also seen in the right upper zone. And then repeat X-ray after on 25th January, after the second of hemolysis, is showing same finding. The right upper zone opacity is persisting. And this last, the third X-ray on 5th of Feb 25, this is also the same. So silent same persistent opacity in the right upper lobe over 2 months. And this is the over X-ray when child presented to us. Child is still having the same opacity in the right upper zone with some part of the right upper zone reserve.
Okay. Dr. Mansingh, I think Dr. Subhashish, any comments on this radiograph?
You are muted, sir.
Sir, you are muted, sir.
So the thing is that it is in the right upper lobe. It is above the horizontal fissure, and the character of the shadow is not changing with different modality of treatment. It is not looking like a cyst also. So that's my take. And there is no air bronchogram which is visible. I am not finding any air bronchogram in this. It is in no other comment right at this moment, but it inhomogeneous outline in the upper part.
Yes, sir.
There is a sharp border in the down, but the upper border is inhomogeneous.
Yes, sir. Dr. Praveen Kumar, any comment on this radiograph?
Yes, because this lesion had persistent opacity, a broad base toward the chest wall. So it could be possible that the lesion arising from the chest wall apart from that. Second possibility, what we are seeing in upper lobe, apart from the white opacity in a more upper lobe, there is cystic lesion. So it could be the mixture of both consolidation as well as cystic. It could be possible whole of the upper right lobe with the cystic lesion having the consolidation as well as the airway space. So these are the two possibilities. And also airway, if you see near the carina, it is not normal. It looks like intraluminal some lesion in this X-ray. So I don't know what is the actual answer, but it is not looking like a pattern. You can see here somewhere, so it looks like some abnormality in the airway.
Okay, so what it is interesting here is that usually if you have a right upper lobe which is involved, you will not have that black spot over it, as if the lateral and lower part of the right upper lobe is involved. So either it is so that the apical segment is cleared, and it is probably the anterior or the posterior segment of the right upper lobe which is involved. And as Dr. Praveen Kumar said, one possibility is that it's probably a pleural based region coming into the parenchyma rather than something originating from the mediastinal side or in the central airway. But yes, usually this tells you that probably it is only the involvement of anterior or posterior segment rather than the apical segment of the right upper lobe. Yes, Dr.
Yes.
Mansingh, let's proceed.
Yes, sir. So apical segment is slightly preserved, sir. So they have done also outside because of persistent opacity. They have done CT scan also, sir, on 4th of Feb after second of episode of hemopsis. So in the lung window, you can see here in the there is consolidation is there in the right upper lobe, and rest of the lung parenchyma appears normal. In mediastinal window also there is dense consolidation is there in the right upper lobe. So
If we have a closer vision, we will be able to. Probably it's too small for us to comment.
Yeah.
You have another image, other images also, Dr. Mansingh?
yes, sir, I have other images, sir.
Yes. We will have a look
Closer
at that.
Closer first I will.
You
closer
have that
view.
video, na? The one which you're just showing.
Yes.
Is it?
Yes, sir.
You can show us that.
Yeah.
Okay. So because of the child having hemopsis, so and this city was already around 2 months, around 1.5 months back. So we have done CT angiogram, sir, and CT orthogram. So in this you can see there is peripheral base lesion is there, which origin from pleura base in the right upper zone, and related to the apical part is okay, but both anterior and posterior segment of lung are involved. And middle and the left side is normal. So in the mediastinal window, this is sitting in the arterial phase. So you can here see that large lesion is there in the right upper lobe with central area of cystic content, and small right paratracheal node is also there, sir, but is not necrosis. So there are lower, that was reported large area of consolidation with cystic lesion in the anterior and the posterior segment of the right upper lobe.
Okay, Dr. Mansingh, is you are saying apical segment is also involved, but you know
No,
the
sir.
apical.
No, sir. Apical is not involved, sir. Sorry.
So in what you have written here is in the anterior and apical segment, but here the apical segment looks more or less cleared.
Yes, sir. Only anterior and posterior segment of right upper.
Anterior and posterior, not the apical. Yeah.
Yes.
So based on this, what was your take on this?
So based on this, then we kept possibility it may be consolidation is there or some cystic lesion is there, sir. And this is persisting from last 2.5 months. Sir. So we plan for we will see airway. is there any abnormality is there, or we will take sample and then we'll see, sir. So we underwent for bronchoscopy, sir. In the bronchoscopy, though I don't have video, the apical, this is the apical segment, it was normal. Both posterior and the anterior segment, this thick whitish membrane was there, which was moving, and it was obstructing both anterior and posterior segment of the right upper lobe. And we tried to suction in out the posterior segment we were able to clear, but anterior segment we were not able to clear, sir. And this means, so this was the ball fluid with this came out. So you can see here some membrane like structure fluid in there, in all over the ball fluids. So because of this, we get possibility of hydrated cyst, and we sent the pneumococcal serology that came positive, but ball chaos was smear was negative, ball fluid, ball signat was negative. In cytopathology, however, they reported numerous alveolar macrophage with degenerated polymorph, lymphoid cells, occasional eosinophil, with occasional squamous epithelial cell under the background of mucoid material. But they were not able to see any scolax in this. And there are no epithelioid cell granuloma and no any parasite they found in this. And AB stain was also negative. Any
Okay.
comments?
Dr. Mansingh? Yes. Dr. Subhashish, what would have been your diagnosis?
So it's completely in line what Professor Minu Singh said. So initially, I with the CT, I thought it is it can be any cystic malformation, but with the bronchoscopy, there is a high possibility of hydatid cyst. So definitely, it is quite an eye-opening thing, and definitely vascular malformation. I was also thinking, but it is not that.
Fine, sir. Dr. Praveen Kumar, what
Yes,
would
yes.
have been your take on this?
Yes, as madam have told, even in the absence of fever, there is no any systemic symptom. Think about the hydatid cyst, and one time I also think about that. But the radiology, the X-ray particularly is not much favor of the hydatid cyst. At one point in time, it looked like the cystic lesion, but it is not coming well into the X-ray as well into the CT scan. And CT scan, if you see, it is a peripherally plus lesion. So how you interpret those peripheral lesions, lung lesion to the hydatid cyst? Of course, in bronchoscopy, it is a very much clear no. It is a hydatid cyst only.
And on the
Thank you. I think
on the lung window, there is a part looks like a ground glass opacity. Is it because of the photo has not been taken? You go back. Not the video.
Okay, sir. This
The
was the
still,
old city. Okay, sir. This was the
Yeah.
old city, sir. This
go
was
back.
the old city.
Here it looks like some ground glassing in the some other part of the lung.
sir, I think the whole
Wait,
picture
it
is
may be
shining
that-
at it's a reflection of
Yes.
probably light.
Right.
it-
Probably. Okay.
Yes.
Okay.
So to me, I think 2-3 things stand out in this case. There
Actually,
are
in
two,
the
three.
video which he had shown, there was definitely the lesion had a cystic part in it. It looks that this must have ruptured, which the patient did not know. And then the membrane is actually something very pathognomonic. Kamal, if you may remember, we used to see these
Yes, ma'am.
cases. And
Yes,
we
ma'am.
reported also, Joseph also, I think they wrote it up also. And
Yes.
that very day, when we were doing this bronchoscopy, we thought that this is hydrated. And even in literature, if you look at Google and you look at bronchoscopic images of hydrated membrane, they're exactly like this.
Yes, ma'am.
And with that kind of history of hemopsis. Hemopsis also occurs, in hydrated only when there is invasion or there is some rupture, so that blood is coming out. Otherwise, hydrated is quite silent, and it would appear on chest X-ray like a big cystic shadow. But many times when hemopsis has started occurring, then that water lily sign also appears in X-rays. But in this particular chest X-ray or in CT, that wasn't there. So it was very atypical kind of presentation of the radiology. But I think it was very typical clinically as well as bronchoscopy wise.
Yes, ma'am. So I think there are 2-3 things.
I have a question. Why the contour of the shadow didn't change over many months from October to?
Actually, in hydrated, if rupture has occurred, then they may not come like cystic shadows. So here the membrane kind of starts invading the bronchial tree, and that becomes blocked, and that has led to collapse in that particular area. But some part of it is still there, which is showing up on CT as a cystic area. I think there was an MRI also which was done in this patient.
Yes, yes.
That can also be seen.
So thank you, sir. Thank you, ma'am. So there are 2-3 things that stand out to me in this case. One, there was a question that we asked that why is the air entry reduced? So this is the reason that in a consolidation, if there is an intraluminal obstruction because of any reason, you will not have air entry which will be good. So in this case, the membrane was blocking the lumen. That's why you in presence of a consolidation, you did not have you had an air entry which was reduced.
Yes, sir.
Another point, that chest X-ray was giving you a lot of information beyond which you did not even get on a CT also. On X-ray, you could say that this is a peripherally growing region. We thought of that. On X-ray, we said that it's not there in the apical region. And on X-ray, we were sure that it looks like an interior or posterior segment of the right upper lobe. And a lateral segment would have even defined that, whether it is anterior or posterior. A lateral X-ray could have given that information. Thirdly, I think the point that there is why the water lily sign and all are not there. It has probably leaked a bit only, so it got superadded infection. So what we see around that cyst is a consolidation, which is in a way hiding, or you can say it is in an X-ray it is hiding the circular silhouette of the hydrated cyst. Had it been a partially ruptured hydrated cyst with some air into it, probably those lumen, those water lily sign, those fallen membranes would have seen. But this was not a hydrated cyst which emptied out well. Otherwise, maybe those signs would have come in. Lastly, on history, we could have asked whether the child has coughed out any grape skin kind of material, which at times can give you a lead very early on. So you can please proceed with the presentation if you have any, Dr. Mansingh.
Yes, sir. So they were not giving any issues, sir, that contains a pathognomic history of that grape-like skin, sir. But we had after that we had an ultrasound, sir. So ultrasound you can show the density of consolidation is there. With these are the floating like membranes, sir. So we'll run here.
There is one more thing I would want to tell you, that sometimes in these hydrated cysts there is a very peculiar smell, which at times from two beds away you could say that there is a ruptured hydrated cyst lying somewhere around there. So at times like ma'am would remember that sometimes with that smell you can make out that there is a hydrated cyst.
Yeah.
So in ultrasound there was these floating membrane, the density of consolidation with like this floating membrane or like there, sir. So they also radiologist also kept possibility of this hydrated only, and just to confirmation for this research purpose that we have done ultrasound, MRI lung, and it is also showing area of consolidation in the right upper lobe with some cystic like content, and in further imaging we can found it some membrane like structure within this cyst. So
I think very well presented, Dr. Mansingh. We have had a very nice discussion over this, very good inputs from the team. Dr. Subhashish Roy, any last comments?
Comment is that you don't keep the hydrated cyst in the lower part of the DD when you are having such a history where there is no constitutional symptom. The child is having an off and on bleeding and the child is otherwise well. Definitely we should think of hydrated cyst in the upper strata of the differential diagnosis.
Yes, Dr. Praveen Kumar.
Yeah, though We have learned a lot from this case, though clinically and radiologically it is not favoring that. But as madam has told, what I learned, if there is a clinical feature not suggestive of constitutional symptom and having those like the symptom, they should keep one of the differential diagnosis as the highlighted cyst. And it also depends upon the geographical area as well as the age of the child. Okay, well presented, Dr. Masood.
Yes, sir.
So thank you, lead discussants. I'll come to Dr. Meenu Singh and Dr. Vyas once more. But I think what I've learned over 2-3 years of this clinical presentation, almost all of them, when they start, they look like a typical case of TB, a typical case of asthma, and ultimately it unfolds to a very unusual case. So I would still say that we should stick to our age-old dogma of keeping the most common first, the less prevalent later on, and go with that. But yes, we should always keep a good big list of differential, so that it's not that it's one in 100 times probably you will get an odd diagnosis also. So think of common first, but do not completely say that the uncommon cannot happen. It does happen, and it brings you down your knees once in a while. Dr. Vyas, any comments from you?
We too had a lot of learning points from it. Initially, we also thought कि it could be unusual presentation of tuberculosis or something a lung cystic lesion or mass or sequestration. And we also thought of कि it could be some lung malformations or vascular malformation which led to the bleeding. But later on, when we discussed it with Meenu ma'am, her initial first diagnosis was hydatid only, and that got confirmed very much in bronchoscopy. So the bronchoscopy image that led to a confirmed diagnosis ki it is hydatid cyst only. So yes, experience do come handy sometimes in these cases. So we are learning a lot from Meenu ma'am.
It's like simply, one experience which teaches us, because this was, I think this is something which in our list in India, in our list of differential diagnosis of hemopsis without constitutional symptoms and all, hydrated should come higher up.
Yes,
So I
definitely.
fully agree with Dr. Vyas, because I was also there with you, that there is knowledge and there is wisdom. So wisdom can give you things which otherwise takes a lot of time. So Dr. Meenu ma'am, any last comments, ma'am? And then we'll wind up the session.
Yes, because when you see that whitish membrane, sometimes you even think of foreign bodies, because when it just makes an appearance, it looks like a peanut. But when you explore, then you find that it is actually a membrane which can be pulled out, and some shreds of the membrane come out. So sometimes the histopathologists are not able to give that diagnosis. Somehow in Rishikesh, we don't have that kind of histopathologist. In PGI, they would have reported a membrane also. So, but anyway, this complement fixation test, serology, hydrated serology was positive in this case. We wanted to have surgery because albendazole can sometimes lead to, more necrosis or kind of liquefaction of the lesion. But the family did not agree for surgery and they went off. So far they are okay on albendazole, but that doesn't actually cure the disease. Sometimes in the lungs, it kind of persists, the lesion persists. So better would have been to take it out and also confirm the diagnosis. But that did not happen in this case.
Thank you so much, ma'am. Thank you. And I thank both the lead discussants for their excellent inputs. Professor Meenu Singh, ma'am, for the very wisdom and insightful comments. Dr. Vyas, and I hand it over to the IAP NRC team. Thanks a lot. Over from my side.
Thank you, sir.
Thank you, AIMS Rishikesh team, Meenu Singh ma'am and Dr. Parma sir, and the presenter Dr. Parihar, and moderator Dr. Kamal Kumar Singhal, our lead discussion Dr. Subhasis Rai and Dr. Praveen Kumar. Thanks for a wonderful discussion on a very common but uncommonly thought condition, hydatid cyst. Thank you so much.
Thank you.
Thank you. A lot of learning. Thank you.
Good night, all.
Thank
Thank you.
everyone.
Good night.
Thank you all. Thank you so much.